So I'm not going to necessarily give you a whole picture of everything going on in America about big data. I want to talk more specifically about some stuff that we've done. And I have to say, since I'm a federal employee, that these are my own opinions and they don't represent anybody else's in the federal governments. But I don't know if that's very controversial what I'm going to say. So just a little bit of history. So I've been working with medical records since 1972. But we built I think in '73 we had an operating electronic medical record system in one clinic at a public hospital in Indianapolis. And we grew. We had big data. By 1995, we had like 10 hospitals connected together, all unified, same coding systems, and linked patients. So the thing that's often left out in some big data discussions, at least in the US, they've got all these sources and it adds up to all these patients, but they aren't linked. That is, there's no connection between the patients in one database and another. And then we built, and I think we sort of invented health information exchanges in the US, which are regional areas where hospitals connect up together with the goal of having the data be understandable across systems to some degree. And then by 2010, it carried about 6 billion test results for most big hospitals in Indiana. So that was, we thought of it as big data. Then we wrote a paper defending a big data in 1991, and it's listed here, and it's got the word humongous in it, which is the first instance of humongous in Medline that I could find. So it was a fun sort of paper, and we didn't really, well, it was an optimistic paper that somehow we could figure out how to use this. And so the final argument was astronomy, well, because the contrast is randomized trials, you know, and the purist will argue that you can't learn very much except from randomized trials. So our counter-argument was astronomy, and they've never had a randomized trial of the universe, and they've done a lot of interesting things, so that gave us some optimism. And there was the final picture in the article was a picture that it was a star that looked like one star, and then they figured out how to take the twinkle, which is an analytics process, out of it. You could see it was actually a binary star. So there's another argument that analytics can fix everything. But we're still kind of wrestling with that whole area about how reliable can we get from big data. So I may be bringing Cole to Newcastle about this, just wanted to point out there's lots of sources today of big data, and Great Britain has mentioned yesterday, CPRD. There's a countrywide Danish databases that integrated together, not an absolute way, but one can get to multiple databases. And Denmark has this special, interesting, because a citizen has to report where they live within 3 days of moving, so the environmental issue can be maybe attacked. And there's something called Mimic 2 and Mimic 3. I don't know if people know about this database. It's out of MIT. It actually has all the ICU data from one hospital, including text, orders, you know, just about everything. And it's tied in with Philips, which is, it's a Dutch company, isn't it? And Philips has an ICU system that's used quite widely. And they have agreed, I think, I haven't checked recently, to deliver a sample of patients from all their sites. And so they're anticipating, it's now at about, this Mimic 2 is about 30,000 admissions, and mostly it was different patients. And Mimic 3, I think, has 50,000 in it. It's a big database, and the anticipation is a couple 100,000. And the same group at MIT is headed by a guy named Roger Mark, whom I was an intern with in 1965. And we still talk about doing resuscitations all night on one patient, and kept reviving him. And then you have to turn over to the new team in the morning, and they quit trying. We were crushed. So was the patient. He was a youngish man. But anyway, so they also have a huge database. It's in the petabytes of ICU electronic signal data, tracings, you know, the EKGs and the continuous monitoring, which NLM actually is a mirror site for. And then Odyssey, which I think was maybe mentioned yesterday, this is a really interesting consortium, I guess, or what you call it. It has 800 million people in it, and it's derived from 50 or more organizations, institutions, ranging from insurance companies to hospital systems. And the deal there is you have to kind of make an arrangement with one or more of the participants to get data, but there's a common database structure which is really worth noticing at a fairly coarse level. It doesn't go down to infinite detail, but across all these participants, they have to deliver a view of their data in this common model. The model is called OMOP model. Now they actually are doing things in a different way than what I'm trying to do, but they argue that the way to get to truth in observational data is to do a bunch of different studies and do the statistics across all these studies. And they wrote, the original OMOP group did a study comparing, they had 10 sources of data, including the Reagan Street, where I came from, in Indianapolis, and they ran the same questions on different databases with different assumptions of the definition of the disease and other different variations, and they all came out different. So this is sort of a worry for big data, and they came up with a solution to you just do a lot of them. And so, for example, if they're looking at a drug study, they will try to find 50 or 60 drugs that are known not to do what they're worried about and compare it with this drug, and then use the statistics across these different analytics to decide what's true. So it's very interesting, and I recommend anybody interested in this business. It's a little bit hard to get your arms around or your heads around. So, Dutch hospitals, they've got a neat database system here, from what I can tell from the web. The Pharmo database, and there's another one, the NIVEL, if I'm saying it right, NIVEL database. And then Estonia, I think, has a pretty neat data set. They've gone down to laboratory tests because they're using LOINC codes, which is a code for observations that I'm very much involved with. And we get requests for new codes from them all the time. Now, there's different kinds of databases, and they have different trade-offs. So the countrywide databases, some appear to be fairly complete, and especially the small countries have an easier time of sort of getting everybody in. And they're mostly complete with respect to prescriptions, medication prescriptions, and encounters, diagnoses, and procedures, because that's usually required for payment and for governmental issues. But there are varying rules about access. So Estonia, I think, as I said, may be the most complete. Some of the countries have good databases, but it's either limited or you can't get at it yet. They're trying to figure out the rules for letting researchers look at it. And I know Norway some years ago had probably the best drug database in the world, but some years ago they wouldn't let anybody look at it. I think they do now. And then there's payer databases. These may be more unique to the US, where the insurance companies collect data, and their coverage typically is just prescriptions and diagnoses and things from encounters. But a few of them have lab data. So it's interesting, in the US, the big commercial insurance companies have required that the institutions from which the patients who are getting data require that the big lab companies, firstly they contract with big lab companies to do the outpatient tests, and they get all the lab results, total. And I'm not quite sure what they do with it, but they're there. But they have little detail about in-hospital data, because in the US it's this DRG, which is a program where you don't have to specify the individual details. On average, they pay you a fixed amount, so they don't submit that detail. There's commercial databases in the United States, which are probably one now owned by IBM. I didn't put the names down of these databases, but these have tried to link data in some of their subsets. So they'll get it from many sources, and they'll work to do various name matching and things to get the people linked together. And they also have, one of them has maybe 700,000 people with labs and other tests. But their bigger databases usually are limited to payment information. So it's a hard business, I think. But I think, you know, there's got to be a pony in there somewhere. There's a vulgar joke, which I can't tell you behind that. But, you know, it's just every intuition is this is going to be a payoff. Now, in commercial uses of sort of big data, they're doing a lot of things. They just will do the mining of things. And there the goal isn't to save lives, or but it's to get a little better leverage on sending out mail to potential purchasers of something. Because it costs, they're still doing this in the US. They send out envelopes with promotional advertising, and these cost maybe $3 a piece to deliver, so it's expensive. And typically, historically, if they got a 1% return on the bingo cards, they have these little cards, they call them bingo cards, that would be a good deal for them. So if they can raise 0.5% to 1.5%, that's a huge savings. So getting a little marginal increase on these big mining things, I don't know if it transfers to healthcare as directly. I mean, if all you could do is a 2% bet for what drug you use, I think it could be problematic. So I want to talk a little bit about, I guess I've already talked about it. I got Odyssey. Back to Odyssey, the one that's a big consortium, they have done some really neat stuff. So one of the papers that one of my researches is on is this, first these references give you a little more. It looked at, so the current belief is that the bisphosphonates are the drugs you have to use to prevent osteoporotic fractures. Bisphosphonates get in and change the calcium in your bones. But they have one really bad side effect, that they create these horrible fractures spontaneously in the jaw and in the leg, which are a fragment, and it's horrible. So that's a rare thing. So there's another drug, which is really an anti-estrogen that's used too, that doesn't do that terrible fracture thing. And they did a paper that showed it's actually better than the bisphosphonates, which I think is pretty neat. I don't know how that'll all play out. Mimic-2 I mentioned, I don't have to go into much data. We did a study on Mimic-2 and found, what our data suggested, that being fat is good. Now that was very welcome to a lot of people in the US, because there's a lot of people who are, fat. And the other interesting thing about fat is that we now have this requirement. A lot of hospitals that you show the patient gets your notes, the handwritten notes. And so often how we describe someone as heavy in medical terms would be a 35-year-old obese, et cetera. And then people are looking at the notes, they'll go, not obese, maybe chubby, but not obese. So you got to be real careful with your words. But it was actually about 20% survival advantage. It's only the super ones above a 40, BMI of 40, super fat, that had a really bad outcome. So Medicare, this is what we've worked on the most. So Medicare has a database called VRDC, and I don't know where the words come from. They used to call it the CMS Enclave, which I think is more descriptive, and we'll describe a little bit. So it includes Medicare Part A, B, and which includes coded office medications, as well as prescriptions outside. That is, I'm going to get to that. So you have all medications given in the outpatient setting, again, not inpatients. They have encounter events, diagnoses, surgical procedures, which function as outcomes in a lot of studies. They're good for outcomes. They also have tied it to the death records in Social Security, so you have vital status. And there's about 100 million enrollees in Medicare, and it's a couple of petabytes, the total data set. But if some of the data isn't that useful. So Part D is all outpatient prescriptions, which began to be paid for by Medicare in 2006. So there's, if you focus on Part A, B, and D, and exclude patients who've moved into capitated care, where they don't get the details, there's about 24 million patients. And you can deal with that movement with regression mechanisms like Cox regression. I'll talk about that in a minute. So, and it has vital status. This year, they also have cause of death information, although you have to be aware that the cause of death is not always scientifically accurate. You know, someone falls over, and the guy who records that death often doesn't know the patient. So they'll say cardiac arrest because it's always true, you know, if someone died. And then they have, by algorithm, they define 40 chronic diseases using tested algorithms by looking at ICD-9 codes in the outpatient and inpatient and weighting them differently. So that's handy, and it has a date. And there's also lots of other information. We haven't gotten into it. There's information on Medicaid, which is the program that deals with people under 65. I'm going to talk about mostly over 65 because it's a uniform, fairly complete population. Oops, I didn't mean to say new slide. So I think their strategy is brilliant. So in about 20 years ago, I tried to get Medicare data, and they would let you get it, but you had to give away your firstborn child and your left arm, and it took years to get agreement on it. So practically speaking, it wasn't available. So the way they do it now, well, they also still let you do that if you give away all these things. But the way they do it now is that you can do analyses on the data you want, but it's inside their system. You don't get to download any of it. So it gives everybody much more comfort on the whole process. They review your request. You have to do it under a request. They review your research request for privacy issues and other issues. And and you have to typically get IRB too from your local institution. So there's a lot of kind of constraints on it. And then they will give you the data subsets, because there's many different databases, and connect them together with unique dummy codes for your particular study. For every study they do, there's another set of unique dummy codes. And they give you a lot of help, and then you run it all on their machines, so the machine time is free. And I'll tell you, they're losing money on us because we're doing these big Cox regressions. So everything is inside the database. You can only download statistics, and I mentioned about the other part. So you make these applications, and if anybody is interested, there is a site that supports it, and I think this is probably available to anybody, any researchers, anywhere. I don't know for sure. It does cost. So for federal researchers, it's $25,000 for the first seat. And your seats, you only get one person on a seat, but they can run many jobs for many people. It's $25,000, and each further seat is $25,000. For people outside of the federal government, it's $40,000 for the first seat, but then $15,000 for every next seat. So it's actually cheaper for them if you got a lot of seats. And then you have to wait for approval, and it takes about 2 months. And then you can get new updates every year, and I think it charged something for that, maybe $5,000. They set up a computer with all lockdown software. You can't do anything else. They only allow now SAS and SPSS, but they're working on R, which is quite popular. And the reason they haven't done R is because they will not put any non-commercial software up for fear of being invaded. And R now is supported, Microsoft has a commercial version, and they plan to put that up. But then it has to run on Microsoft servers, and they have thousands of servers, and most of them aren't set up as Microsoft servers. So it'll happen. Stata, I take it. SAS and Stata is what they have. And if anybody wants to look at all the details on it, I've got a website there. Now, Cox Regression, are people familiar with Cox Regression? There's someone from Erasmus, actually, who's written a lot of interesting papers about it, and I should have connected a paper. I would love to talk to him, because it's a complicated analysis technique. And it typically predicts, so I'll give you a little explanation. It predicts time to outcome. So, time until a group of population dies, and it's especially useful or needed and almost always used now in time series data, temporal data. And the studies that have compared it to other things like logistic regression, it has more power. It's a better method than those if you got time series data. And it's kind of wonderfully accepting of complications. So you accommodate censoring, so that if the patient leaves your database, that's okay. It'll still work out the statistics correctly. if loss to follow-up, delayed start. So if you have some people who started in one time and some other ones were, say, they were off in Europe and didn't get any records data until they got back for 3 months later, it accommodates that too. It doesn't care about the statistical distribution of covariates. You can look at continuous variables, you can look at categorical variables, binary variables, and it doesn't really give a hoot what kind of a shape the distribution has. And it can consider one or consider many outcomes, and it can deal actually with chunks of time in the middle of your observation that have no data. Sort of a funny specialized censoring. And it can also, so a lot of times, if you're looking for the outcome of time until the first cancer, well, a lot of times those people die on the way to while you're waiting. So it's a different outcome, death, and they have special ways to deal with death as a competing risk to the outcome. So how it works, and I may not explain this well, but I think it's really pretty cool when you get inside it. So you take all your data, your whole data set, and you choose an outcome of interest. Typically it's death, but it could be first heart attack or something. And then you sort your patients out in order, time order of the occurrence of the event. I'm going to assume there's N patients, and then I'm going to assume K of them suffered. Maybe this is unnecessary. So you sort them all in time order. Then you take the very first event in that time order, and you compare that individual with all the other individuals who are still in the comparison cohort, which is typically everybody else who haven't yet suffered the event. And then you cut off all the data at that time for all the other patients, all the other people. So you look only at covariates that occurred on or just before that event time, and you do a statistic. And then you repeat this for all of your other individuals, each event. You only look at event people. And then you do another thing to wrap all the statistics up to get a hazard ratio. It doesn't care about the interval time between these events, but it's very important for the order. And then I kind of said this all that. So it gives you a hazard statistic that tells you bad or good whether this thing has an effect. And it does it also for all the covariates you've included in the database. And you can't, the tricky part about it is, it's tricky, I guess. So you cannot use any information from the future. It's related to Martingale probability theory, which is based on an 18th century French gambling strategy, which kind of is like keep doubling your bets and you'll finally come out okay, but it doesn't happen in real life. But there's many ways you can break this rule without noticing it. So for example, if what you take for your covariate is the average data across the whole time the patient's under observation, that breaks the rule because whatever that time cutoff is, it's using weighting from the future into that. And it isn't always easy to recognize that you cheated on this. And the other problem is, this is what bugs me, is that you do slightly different analysis and sometimes the results flip. And so we've been looking at trying to see what are the rules you should follow to keep results from flipping to go a different direction. The other one, I've been talking with a real expert on this from Mayo Clinic, and there's another subtle thing is if you sub-select your population based on what they've ever had, I can't get them to commit, whether that's cheating too, because you're looking into the future beyond, so I don't know. So what we've been looking at NLM is unexpected harms or benefits from treatments, especially drugs. So that's what we got permission from our request to look at. And we looked at a lot of things, but we're still, a lot of them, wrestling with the Cox regression and how to find the stable pathway through it. So we did look at the risk of Alzheimer's from androgen suppression. So one of the treatments of prostate cancer is to knock out testosterone and all the androgens effectively. And so there's a paper that published that it increased the Alzheimer rate by 20%. So that really made people worry about this. But we did a whole bunch of different analysis using 38 chronic disease, demographic, rural status in I'm sorry, this is a different study. We did a whole bunch of studies. I'm going to talk about this later one in a minute. And we found that it actually was slightly protective against Alzheimer's. So I think people don't have to be in panic right now. The paper that is published in Clinical Oncology is referenced below, and I mixed the slides up. There's 3 things here I'm going to talk about in a minute. Let's see, how do I make these go? I was doing fine at, oh, here we go. So we think there's sort of a best practice, but we don't know if we haven't really got it vetted that any covariate, all covariates, you shouldn't do non-time varying covariates. You get into trouble with the mortality, there's a thing you get in trouble with, immortality bias. If you're looking at outcomes, say the first occurrence of a heart attack, and the death rate is high compared to the incidence event, you really got to do a competing risk to take into account people who died. You probably should always use propensity methods. Now, there's still questions about which ones. You know, people familiar with propensity scores? Well, what you do is you do statistics to find out the likelihood that someone will be choosing a treatment, and that kind of balances off some of the biases, and then you adjust your covariates for that propensity score. The another way to do it is you balance you do matching of your population, those with the thing and without, with propensity score, and there's arguments about which is the best. We routinely do propensity scores to adjust the covariate values, but it constrain the outliers because crazy stuff happens. We have if it's way the heck out of like an error of data. It probably should define a washout period to get incident versus prevalence, but that's another big tricky space. What I've said here, I've gotten retorts to, so I'm not really sure what's the right way to do it. You could do right censoring, as I mentioned, to delayed outcome, and this is in doubt. I wrote this 2 days ago. Talked to a guy last night, and he said, maybe you have to just chop the patients out. Now, I want to talk. I had some other slides, and I'm sorry. So we've done some other studies on the Medicare data, and we have a number of them we're working on now. So one of them is on metformin. So metformin is a drug for diabetes, and it's the most commonly used drug for diabetes, and it works well. Some think metformin is a fountain of youth because it has metabolic effects that are just like the effects of fasting on animals, or the reduced diet restriction on animals, which in some animal species, they live 20, 30% longer. So there's some theories that think metformin would do the same. So we've done some big analysis, and we included in the analysis all the other diabetic drug classes, statins, and blood pressure meds. So metformin looks like it's a good drug for diabetes in terms of survival, but it doesn't trump the newer, maybe that's not the right word to use. It doesn't top some of the newer drugs that are out there. In fact, some of them do a lot better than newer drug classes for diabetes, and it doesn't come near the effects statins have on survival. So, if you haven't started taking them, you might as well start now if you want to live a long time. We're looking at there's this class of antibiotics, ciprofloxacin is one of the common ones, that are suspected to cause tendon ruptures and maybe aortic aneurysms. So we've looked at that too, and it looks like there is an association between. What we did, we looked at this class of drugs, and we looked at a class of macrolides and amoxicillin, some other commonly used outpatient antibiotics. And these ciprofloxacin-like drugs do have a higher incidence of aneurysms and aneurysm ruptures. So it's worrisome. We're looking at, there's a couple other ones that we're looking at that either stuff may do good or bad. Statins are also reputed to have an advantage for Alzheimer's disease. And we don't see it, but it's very complicated because when we do these analyses, we also are looking at death rates. Statins have big effect on survival, and of course, you get Alzheimer if you live a long time. And the so-called competing risk doesn't seem to fix that. So what makes us worry is lung cancer, which has the highest, it's a 6-fold hazard ratio, also protects against Alzheimer's. But obviously, it's because they don't get there. So we're still wrestling with that space. Now, you know, if there's a little time, I thought I'd talk about, well, there's other things. Deep learning. You all heard about deep learning, right? Or this neural network stuff. It is indeed, I'm not going to give you a lot of details, but it's impressive. We've done a number of studies, you know, analyzing images, analyzing text and things, and it does better than all the other machine learning processes we've tried before. And some of these problems aren't amenable to regular statistical processing. Not only that, there is now a deep learning adjunct to Cox regression, where you figure out one of the analysis methods, you stick in the deep learning outcome into this Cox regression, and you get a kind of a neat result. It's brand new, so that's not been critiqued very well yet. And what I'm going to do, this is slightly the wrong set. I got another set that and I'll get you that for the slides. Okay. And one other thing I want to talk about a little bit is, and deep learning is going to be a big deal in big data, because it accommodates, it doesn't care about much of anything. You know, you take your set and you do some comparison things, and it'll actually find out true relationships amongst it, if you have lots and lots of data, which big data is by definition. So, so what I want to talk just briefly about, but it's in this other slide better, HL7's fire. Did anybody hear about that? Yeah, because it's really, it's on fire. It's on fire in the U.S. So Apple Health has got this application for a personal health record that is built on fire, and I'll tell you in a minute what fire is. Google is into fire, and Medicare, which is the most powerful payment organization, has now announced a product based on fire. And all the federal agencies are looking at it really hard, and industry is very supportive of it. So it's really sort of an interesting thing. And I don't know exactly how to describe it. It's sort of like a communication system. It's like HL7B2. It has a lot of the same capabilities, but it's an API rather than the messages being sent. I don't know, time? Okay, well, we won't go too far. That's enough on that then. But it's really catching on, and I think it'll allow the aggregation of all kinds of data with the same codes and no problems with linking inside of a patient's record, who they'll have freedom to give away for research or the like, plus other things. All right.
Thank you.
We'll get the right slides up for you.
Okay. There's still time for a few questions, and I'll look at the audience. Again.
One thing I know you've done in the past is the concerns about using observational databases and that sort of stuff, right? So some of the stuff you've addressed, the Cox regression, but also propensity score matching to make sure that you compare apples with apples, right? But the other part is the missing data, right? I mean, obviously in some cases tests are not ordered, information is not collected, and sometimes it is, and you can't assume that that's all at random. So what are your thoughts about that? About what should big data researchers understand about missing data?
Well, I think that's definitely a problem, and some people use imputation or select out those who don't have missing data. But Cox is relatively insensitive, and the deep learning is also relatively sensitive to missing data. But it's an issue, so I don't know that we have a formulaic solution to it, and I think you do have to worry about it. If you don't have any, if you take the extreme case, it's almost all missing. You're not going to get any predictions out of it, and at least that use it, you'll get misinformed. Yeah.
You had a question, Anna.
Yes, about the HL7.5, so that's a standardization protocol for medical terminology. Right?
I'm sorry, repeat that.
The last thing you mentioned, the HL7.5, the standardization protocol for the terminology, for the medical terminology.
Well, FHIR it's going back and forth. So FHIR gives examples of the right terminology, and there's right now a fight going on that they should insist on a given terminology. But because terminology is so political, a lot of times I think they're trying to avoid it. So in the US, for observations, they do recommend LOINC. And for diagnoses, they recommend, well, I don't know if they've taken a hard position, it's no matter ICD-10 for diagnoses. And there's some other things that are internal HL7 codes that they actually have to use. But that's an issue. Operationally in the US, the meaningful use is specified codes, and that's what people are adopting in FHIR. So Apple Health, you'll see LOINC codes for the diagnoses and SNOMED codes for the LOINC codes for the observation lab test and like, answer codes. And it's really there. I mean, we had 2 people outside of our office comparing their records, their personal records on their Apple iPhone. And it's in 44 big institutions. They only announced it 3 months ago, and it's catching on. But the beauty of it is they are forcing the institutions to let their data free. Because one of the big problems in the U.S. is they kind of hang on to the data because it's an advantage to their recruiting patients. So I think they're going to break that with this thing. And it's patient, they're controlling it, so there's not a problem there.
So my question on that was, is there any project going on ontologies that could possibly do this more automatically? So it's not just a guideline, but it would translate different, from different disciplines, things that are in theory the same, but they're mentioned in different ways, or from different languages, contexts. So it's always...
Well, FHIR is very...
it's a big thing, so many languages, so...
Languages shouldn't matter. FHIR has, any coding systems can have language variants in them built in, one or more in the same message. And the idea is the code has the meaning, so you have to be sure if you got language differences that they've been aligned, that they're correct. So, and in terms of observations, you have to have a publicly available code of some kind. You can't work without it. But I wasn't sure whether I've answered your question. Okay.
Continue to
Yeah,
add.
we can continue.
Okay. Very much, thank you.